Hi guys, Cass here. Obviously I don't have Lee with me, otherwise you'd be able to see her. But today what I am doing is it's supposed to be a new series, sort of. It's similar to the Convos, but since I am taking a class this semester about psychology and it's called psychosocial nursing. I was thinking maybe I could share that information with you guys. Um, and it's to help me study, specifically to help me study, because I find that teaching someone something is a lot, it helps me with my studying in general. So, what this episode about is kind of like the mental health nursing assessment. And so what we're going to start with talking about is the DSM-5. And I have my laptop right here, if you can't tell by the glow. It's just notes because I don't have it memorized. And so the DSM-5, it is the book, a lot of people have heard of it, the mental illness book or whatever. It identifies and classifies mental health disorders based on a specific criteria. And I've looked in the DSM-5 a couple of times, just researching a couple of disorders. And there's like a certain amount of criteria you have to meet before like you can be diagnosed with that disorder. And so moving on with the psychiatric mental health nursing assessment, that's what like I would be doing if I went into like psychosocial nursing, which is like the psych wards and stuff like that. You're looking at their psychosocial status, which is subjective data, their mental status, which is objective data, risk assessment, physical status, labs, and medications. So the most important part is the risk assessment, because that's if they're a danger to themselves or others, like with suicide or homicide. And so the psychosocial status is the patient's perceptions and recollections of their life right now. The mental status is their cognitive processes. So there's several different ways that we test these, and depending on which like set of notes it's in, it's either going to be this episode or video or one of the next few. And so the physical status is vital signs, and then labs, which is, CBC, complete blood count, toxology screen, stuff like that, like when they take their blood, and then medications, which I think almost everyone knows what medications are. So during this assessment, it has to be confidential because of HIPAA, and that's one of the things that you have to communicate with your patient. So for the psychosocial assessment, more in detail, you want to find you want to derive something like that. Their reason for admission, precipitating factors. So the reason for admission is like what they came to the ER or the psych ward for, and then the precipitating factor is like what broke the camel's back. And then circumstances surrounding admission. So for that, reason for admission would be like depression. Participating factor would be, oh, my girlfriend broke up with me 2 days ago. Circumstances surrounding admission, my girlfriend broke up with me 2 days ago, Our relationship hadn't been going well for a year. We were fighting all of the time. It was draining. I got in my car and I tried to crash it, kind of a thing. Previous psychiatric treatment, inpatient, outpatient, are they seeing a psychiatrist, a psychologist, have they been admitted before? And then the patient's expectation of hospitalization. What do they expect to get out of this? Do they expect to get better, or do they have no idea why they're here? They think they're fine. Coping mechanisms. So coping mechanisms are, how do they deal with stuff? An unhealthy coping mechanism would be, oh, I take cocaine. It makes me feel good. I actually don't really know what cocaine does, except physiologically. I know when you're on cocaine, your pupils go to pinpoints, I believe. Pretty sure. And I'm pretty sure it's a stimulant. Yeah, so it makes you feel good. I don't know. Most drugs do, don't they? Anyways, and then a healthy coping mechanism was, when I'm angry, I go and paint. Or when I'm sad, I read, kind of a thing. But I think reading can technically devolve into escapism if there's too much of it. The patient's perception of stressors. So what do they view as is the most stressful in their life right now? Spirituality. So this isn't are you Christian? Are you Hindu? Are you Muslim? This is, what gives your life meaning? What gives you strength and hope? Who do you turn to in times of stress or crisis? So what gives your life meaning can be God, or it can be my son, what gives you strength and hope? And then we really, for the who do you turn to in stress and crisis, we really want to assess and see if they have a support system. That's important. Another thing to mention about the stressors is that something that's super stressful to me might not be stressful to you. And then something that's super stressful to you might not be anything at all to me. So that's kind of why it says perception of stressors. It's not doubting that something's stressful, but people have differences of views on that sort of stuff. Moving on, self-esteem. We want a rank of 1 to 10. So for a physical assessment, the pain assessment, 1 to 10. For psychosocial assessment, self-esteem, 1 to 10. And then a history of sexual, physical, emotional, psychological abuse, and intimate patient violence. A lot of the people that are in not necessarily in psych wards, but have a lot of mental health issues, also I think have a hard time seeing if a relationship is healthy or not. And so there can be a lot of domestic violence in these kind of situations. All right, so drug and alcohol use, abuse, or dependency. So for this, you want to figure out what kind of drug it is, what type of alcohol, if it's wine, if it's liquor, how many years have they been using it, when was the last time they used it, date and time, history of withdrawal symptoms, have they been to detox, or have they detoxed, have they gone to rehab, if they're sober or clean, how long have they been clean, Do they go to Alcohol Anonymous or Narcotics Anonymous? And then do they have a history of a DUI or DWI, which I don't know what that is, to be honest. I just have it written down here. Anyways, I'm sure that won't be a question on the exam. Arrest related to drug and alcohol. You want their educational level. If it's a child, their grades, their grade failures, if there are special needs. You want their social patterns. Who's their family? Who's their friends? Who do they live with? Who do they turn for in support? Again, support system, super important in these situations. And a lot of people don't have them. Sexual patterns. Are they sexually active? Their sexual orientation. Do they practice safe sex? Do they use birth control? And do they have children? If so, how many? Again, if it's a child, well, I mean, sexual patterns would be like, the doctors start asking you that around 14 or 15, I believe. That's when I was 15, I think, when my mom had the talk with me. But I know troubled children can experiment in that way. Anyways, for children, the types of discipline used at home. Is it healthy discipline or is it abuse? Legal involvement. Have they ever been arrested? Do they have any crimes? Do they have any warrants out for their arrest or tickets? And then their job status or history. Like, if you're mentally unwell, generally you might have a hard time holding down a job. So you kind of want to figure that out with the patients you're assessing. How much sleep do they get? Do they have difficulty falling or staying asleep? And do they use melatonin or any over-the-counter treatments? Or are they prescribed anything? Their appetite. Is it decreased, increased, weight loss, weight gain? And if so, in what period of time? So you want to assess their appetite because it can be decreased with like depression and stuff, and increased, I believe, in I actually don't know what would cause it to be increased. Exercise. Do they exercise? Because exercise releases dopamine. How do they appear? Are they clean? Are they well kept? Do they have dirt under their nails? Is their hair greasy? Is their shirt stained? Because appearance can really tell us how they're functioning within their lives. Psychomotor activity. So this is like tics. Like, do they have any tics? Can they move well? Can they like do that kind of a thing? Orientation and level of consciousness. Are they alert? Like, are they responding to you? Do they know where they are? Do they know why they're there? Do they know their name? Do they know what year it is? Kind of a thing. Behavior and attitude. How does the patient behave and act, like verbally and not verbally? Like, when you're talking to them, how are they acting? And like, what's their body language saying? Are they closed off? Are they open? Kind of a thing. Speech, you want like pace, volume, clarity, if there's any impediments, which I don't think I have one, but inflection, content, and abnormalities present. So abnormalities would be what we refer to as clang association or word salad. So clang association is when they're saying something that doesn't make sense, but the words rhyme. So it would be like a patient saying, I'm queen, I'm mean, and I'm lean. And then word salad is when they say words that just don't make sense, don't string as, it doesn't like string together as a sentence. So, we've moved on to the mental stats exam. What I was talking about was the psychosocial exam, the mental stats exam. This is the objective data. So we want to know their memory. Immediate and you have to test it. So immediate, have them repeat 3 words back to you immediately. Short term recalls those three words at the end of the interview. Long term, date of birth or what they ate the night before, and you have to be able to verify like what they ate the night before. Their emotions. So mood is subjective, affect is objective. So mood is, how are you feeling today? Oh, I'm mad. Affect would be that facial expression. So the way that we describe this is appropriate or inappropriate. So appropriate, it would be like, I'm mad. You can tell my face says I'm mad. Inappropriate would be, oh yeah, I'm so sad, kind of a thing. Like, they don't match. Blunted is when they it matches, but like it would be like, I'm mad, kind of a thing, not as, and then flat would be, I'm mad. So those are just kind of like examples. So perceptual disturbances. Are they having any hallucinations, illusions, and then dissociation? So with all 5 senses, you can have hallucinations. Auditory, visual, tactile, olfactory, and gustatory. So the most common, I believe, are auditory, visual, and tactile. Illusions would be misinterpretations of a real experience or an object. Like, this is a rat, kind of a thing. And then depersonalization is a type of dissociation that is altered perception of self. Derealization, also another form of dissociation, altered perception of environment. So thought process. So those are how their thoughts are organized and how it's expressed through speech. So like right now you can tell that my thoughts are organized, mostly because I'm using notes, but it's linear and what I'm saying is making sense. So abnormal findings within the thought processes would be rapid, disconnected, disorganized, off-topic, and repetitive. So if they're saying the same thing over and over again, you ask them a question, they say something that doesn't quite connect. Disorganized, they're kind of bouncing all over the place. Disconnected, I would say that's similar to disorganized, bouncing all over the place, but it could also be like they answer you, but it's hard for them to focus, kind of thing. And then rapid, just very, very fast, which can be, the rapid I think can be found a lot in anxiety, and disorganized can be found a lot in ADHD. Thought content, so what are they thinking about, what are they describing? And then within this, delusions, which are false beliefs, which would be like, oh, I'm the Queen of England. I'm American. I'm obviously not the Queen of England. And they, kind of thing. Suicidal ideations. So, do they want to die? Do they, on a scale of 1 to 10, do they want to die? Types of attempts, plans, means. Do they have access to the means? How they feel or felt after a the suicide attempt that they had. Homicidal ideations. On a scale of 1 to 10 again, towards whom? The relationship. For what reason? The threats made. Plan, means, access to means. how resolved, how they felt after the attempt. So homicidal ideations are not commonly found in adults, but they're oftenly found in children, troubled children, because children don't have a perception of the permanence of death yet. Like, I think you have to be around 12 or 13 before you really start like realizing death is permanent. Abstract thinking. So this is another test that, like, it's another thing you have to test. It's not something you observe. And that would be asking them something along the lines of, describe to me how what the early bird gets the worm means to you. So there's either two answers. Concrete thinking or abstract thinking. So I'll start with abstract thinking first. The early bird gets the worm means that the person who arrives first gets the best, like, object, like promotion or something. Concrete thinking would be like, oh, the bird that wakes up earliest gets the worms first. So it's like very literal. Attention and concentration. So spell world backwards, count 1 to 20 as fast as possible. I started reading that saying that before I started reading that. For adults and adolescents, you want to count backwards from 100 by sevens, which I don't think I could do. But even if you can't do it, it's like, are they able to focus and think about doing it? Like, it would be like 100, and then 93, like, you can tell I'm able to concentrate on it, even if I'm going slow. So for those that are developmentally impaired, spelled world backwards. Young children count 1 to 20 as fast as possible. Older kids count 20 to 1 as fast as possible. And if they cannot complete counting, 3-part direction, give them a 3-part direction to follow. Impulse control. So this is related to aggression, fear, affection, hostility, guilt, sexual feelings, kind of a thing. Judgment. Are they able to make good decisions? So it would either be recent behavior. Well, you consider their recent behavior, and then you would ask them something along the lines of, can you, what would you do if you were at a crowded concert and you smelled smoke? The correct good judgment answer would be find someone and, like, tell them, like, one of the, like, workers, or pull the fire alarm. Bad judgment would be, or fair judgment, I think that's the word, would be screaming fire. Actually, no. That's poor judgment. Poor judgment is screaming fire. Fair judgment is when they just leave. Because, like, you're going to let everyone else burn to death? Kind of thing. Insight. How well do they understand their diagnosis and their treatment? Or their functioning? Like, do they know why they're there? At the psych ward? Kind of a thing. Excuse me, sorry. Do they, like, are they willing to change? Like, are they wanting to change? Would be good insight. And then poor insight would be, I don't know why I'm here. I'm fine. And then fair insight would be like, well, yeah, I'm not fine, but nothing's gonna change, so why try? Developmental levels. So, Erickson's 8 stages of development, which I cannot recite to you off the top of my head. So give me a second and we will talk about that real quick. Erikson's stages of development. All right. So what we have is stage 1. Infancy to 18 months is trust versus mistrust. So an infant is learning, like when they cry because they're hungry, that their mom is going to come pick them up and feed them. Which is why you don't want to just let your baby self-soothe. Babies cannot self-soothe. They're crying because they're helpless and they're hungry. Stage 2 would be toddler years to, so 18 months to about 3 years, autonomy versus shame and doubt. So this is like their potty training and doing stuff on their own kind of a thing. Preschool years from 3 to 5, initiative versus guilt, which would be so like, are they good or bad? Like, am I good or bad? What's their purpose? So yeah, I just didn't remember the names of them. Stage 4 is industry versus inferiority. So middle school, so 6 to 11. So like that's like they're doing good at school and stuff like that. 12 to 18 is identity versus confusion. Who am I? 18 to 40, intimacy versus isolation. Finding a partner. 40 to 65, generativity versus stagnation, which is like building a family. Are they changing the world kind of a thing? And then stage 8, which is 65 to death, integrity versus despair. Am I proud of my life kind of a thing? So that's all I have for you for this video. So this will be a series until about the beginning of May. No, I think it would end in April. Yeah. So this is going to be a series for the next couple of months. Well, I'm filming it for the next couple of months. Now that I think about it, it's probably going to be being put out like once a month, and then the other 3 weeks are going to have different videos, because I don't want, I personally, I don't know how Lee feels about this, but I don't want like the same thing every week, just because I like variety. Anyways, thanks for watching, and I'll see you next time.